years in different positions like treasurer, secretary, and vice president. Thank you for being here, ma'am. The floor is yours, sir and ma'am.
Check. Thank you, Astaji, for introducing your kind words for us, for both of us, and thank you, NHRC, for giving this opportunity to chair this session, this STEAM session, and this is the last session also of the summit. So. It's very pleasure to have all the eminent speakers we have here with us to share their experiences, their work with us, among us, and it will be surely part of this summit, declaration. I hope so. So without making any delay, I would like to invite. We'll introduce one by one our speakers, presenters, because we have not much time. So I'd like to invite our first speaker, Professor Dr. Bibu Paudal. He is a professor appointee at King's College London, and likewise he is the fellow of European Society of Clinical Pharmacy. Dr. Paudal was an associate professor in clinical pharmacy and pharmacy practice. He is an active researcher and educator in pharmacy practice. As of January 2023, he has published over 100 peer-reviewed publications and has consistently secured external research grants and awards. His research focuses on identifying and addressing the causes and consequences of health inequality, pharmacy and public health, self-care and development and evaluation of innovative pharmacy services. You have 20 minutes. You have 20 minutes for your talk, and please stick your time for your talk. Thank you.
Thank you, Harisar and Santa ma'am. It's really special to be back here since 17 years after leaving the country. Never had the opportunity to present at a conference like this. So I'm moving to King's College London, but my trip has been funded by the University of Birmingham. So I'm going to be introducing myself belonging to University of Birmingham as well as King's College London. And although I come from pharmacy background, my area of interest is health inequality. Particularly I work with people experiencing homelessness, substance use, mental health, and overlapping problems. And I'm going to be introducing some of one key project that I'm leading just now. And I think over the years, we have had some experience of how to involve, how to consent patients and participants in research projects, because we particularly work with people who may have compromised capacity to consent in a research project. So I was speaking to Meghanathji earlier, and he said, a session on a methodology would be really valuable addition to the session, to the conference, and I'm trying to do my best. So this is where I'm until the end of May, University of Birmingham, and I've had the pleasure to welcome some of our NHRC collaborators last year there. It's a very well-known university with about 39,000 students, some of them from Nepal, and we have quite an intense research culture, and I think I have to justify research also to maintain my job as well. So it's not just something that I would do with an interest, but it's a mandatory part of my contract as well. And as I said, from next month onward, I'm going to be in London. So this is my area of interest, and we have developed pharmacy services for people who experience homelessness. And in the UK, and I would say in the most of the urbanized Western world, one of the growing problems is we have homelessness due to, I would say, multifactorial challenges that's leading to people sleeping rough in the street, risk of eviction, living in temporary accommodations, and this is how the UK government defines homelessness. And if we count, in Europe, so let's say that graph is showing how many people sleeping rough in the streets in England. It's about 4,000, between 4,000 and 5,000. But if we combine everyone, that's about 300,000 in the UK, and about 700,000 people in Europe known to sleep rough in the street or spend night in the temporary or emergency shelter. And I became quite interested in this while I was in Scotland doing my, that was the first academic job I was in, doing lectureships. So I sent students to actually interview these people about how do they access health services, how do they manage medications when they have nowhere to keep their prescribed medications, or even not having access to any medicines at all. So this is the kind of a stark inequality we're facing with. The mean age at death of homeless persons in the UK is about 46 years. And for males and females are particularly disadvantaged due to this inequality. And 40% caused by poisoning and often intentional suicides, but also due to lack of education about drug consumption. So this is a service that I'm currently leading. It's a randomized control trial funded by the NIHR in the UK. So what we have just now is a pharmacist. So any people who are experiencing homelessness or related comorbidities or social disadvantage, we recruit patients from community pharmacy and then offer them a 6-month support on a weekly basis by collaborating with a third sector homelessness support worker. So we have quite an integrated care coordinated between the health service and the third sector, and we measure outcomes in 3 months and 6 months. So pharmacist does the whole body check in terms of screening for diseases, mental health, substance use, the physical health conditions, and the third sector worker deals with housing advice, social support, prescribing, welfare benefits, debt, and so on. And that's 50 and 50 in usual care and Phoenix intervention, we say, and the outcomes assessment in 3 and 6 months are we're trying to see whether we can actually speak to patients, to these people, whether we can actually recruit these very disadvantaged population in research, whether we can retain them, whether we can follow them up using all the existing resources, by liaising with third sector, and also for the progressing into the main trial, we're interested in whether we can actually reduce death, we can reduce their emergency department admissions, hospital quality of life, and many other measures. So one thing we have learned as part of this trial, and also doing similar other related trials and work, is how to kind of respectfully obtain informed consent from the most vulnerable people in the society. And I can see quite a focus on mental health in this conference, and hopefully some of the learnings that we've got here will be beneficial. So informed consent, by definition, we say when a subject or a potential participant voluntarily confirms their willingness to participate in a particular study after having been informed of all aspects of the study, and they take the decision to participate and in traditional way offer a written, signed, dated, informed consent. But sometimes, some of these red bits, so how to sign, even maybe there's aspects about health literacy, there's aspects about mental capacity to understand and embrace the information that compromises our ability to recruit them in the trial. So 3 key elements: adequate info, voluntariness, and capacity. And that's where the last bit, the capacity, is a particular challenge when undertaking research with the vulnerable population. So when we recruit this particular group of subjects in our research, so the capacity to consent, and also applies to other research as well, is traditionally based on whether the subject can understand, evaluate, and retain the information to be able to make a decision. Yeah, so that's the first bit. But then how do we evaluate this in a research environment when we have 5 minutes, 10 minutes to go through the information with the potential participant? So one thing we can use is a teach-back technique. So once we have offer the info in the most lay-friendly way, often by using, let's say, representatives from patient charities, lay members, lived experience members within the research team. We use them to relay the information, because often healthcare professionals are not the most, the best persons to be communicating that info to participants. Even simple questions like, what's the date today? So if they can, answer that question well, often we make the first impression that there's a capacity to consent. And also, it depends on where are we providing the information, whether it's a setting that the patient or the person is comfortable with, whether it's a health services setting. Sometimes some of these people have lost trust in the health systems. They've been left out of the systems and now back in the streets. And that's where the barrier to kind of consent them providing adequate information. So it depends on where we are consenting, where we are recruiting from. So often a pharmacy or a health clinic is not the best place to recruit some of these patients in the trial. So we go to their temporary accommodations, we go in the streets, we go in the shelters, temporary accommodations, and charity places. And impact of emotional state can also be impact on capacity to consent, as well as physical health. So one thing we need to be quite aware of when defining vulnerability or even capacity to consent is to avoid the group-specific attribution. So one thing to note is, let's say not everyone who misuse substance have lack of capacity to consent. Every individual is different. So we don't treat people as one group here. So it's the individual assessment of capacity to consent is really important. So not everyone with psychosis, schizophrenia are the same. Not everyone under the influence of alcohol or substance on that day when you encounter them in research are the same. So we need to assess individual capacity before we make a decision to actually invite them to enroll in the trial. And also, capacity can be temporary. So when you see the patient today, on a different day, they might have a different perception. They might demonstrate a different capacity to consent, to understand the information and provide consent. So the ethics committees often, and by Mental Health Act in the UK, it mandates that the possible inclusion of subjects who lack capacity to consent in a study should be specifically mentioned in the research proposal. And this is to protect the individuals, is to avoid any exploitation, and to respect their privacy, and to abide by the wider governance regulations we've got. So what happens when they are assessed to have lacked capacity to consent? Now, it may be related to, so let's say this trial is about improving lives of people who are most disadvantaged in the society. So by not undertaking the research, we're actually disadvantaging them. So lack of capacity to consent doesn't exclude people from every single study, from every single trials. So one approach that we have used is to use family members, carers, their trusted persons, who can help them take that information, relay that information to the person, or even when they have not got the capacity to consent, they will tell us what would the patient have done if they had capacity to consent for this particular study. We can use their healthcare professionals. Let's say if it's particularly in trials in a hospital setting, they can also consent, and also nominated third parties such as the lasting power of attorney. And we may not need always a signature. So, but in a trial of investigational medicinal product, that's where a signature from a third party or a proxy is actually needed. So their best interests be protected. So the aspects where the mention of the involvement of people who are vulnerable is because we need to be making sure that they're protected, not exploited, and also, but at the same time, not discriminated against in terms of advancing their treatment and care. I think I've described the first two. So the third one is the implied consent. So what happens is, we have recruited people into the trial. Now they're into the trial timeline for about 6 months, but maybe 3 months down the line, they may lose a capacity to consent. Maybe their mental health deteriorated. They may be using more substance, or when the researcher encounters in that day, they find that the person is no longer able to provide a repeat consent. What do we do in that situation? Again, we can use trusted members, families, charity persons to ensure that the person would still be willing to continue in the trial at this stage if they had the capacity, and implied consent. So fortunately for this trial, we didn't have to use it, but for the Phoenix randomized control trial in community pharmacy, but there is that provision as well. And deferred consent, we haven't used, also rarely used, but it's when there are studies about potentially life-threatening conditions, when there's no other way to kind of offer that investigational treatment, and if we don't offer that treatment, the only outcome is perhaps the death. That's where the deferred consent, which is about obtaining consent after the person has regained capacity and consciousness, is also used. Okay, so further considerations, rapport, relationship, building that relationship, rapport with the patients is key. As again, using trusted members, charities have been really useful. Make connections, so even I have shadowed in the streets with our recruiting researchers, so we talk about football to start with. Make that connections for the first 5 to 10 minutes before we actually talk about research. Just simply asking how was the day does help. And also, we don't go in suits and coats and laptops. We use paper forms. It's very different to, trials, where we kind of often see, in hospitals, we've kind of, it's a different approach to recruiting people when you're working with the most vulnerable in the society. And time constraints, let's say many of our people could be begging in the streets. And if we're asking them to stay with us for 1 hour, they will lose that kind of income for that day for an hour or two. So they haven't got a lot of time for us to offer. So what we do is, offer them incentives, food parcels, vouchers, and that can help. And keeping information short and factual. What's the thing that you want to communicate most important? And we've used previously abbreviated consent forms, but not in this trial. And that has been approved by some committees, but other research committees don't like it. Right, so I'll skip this for the time. Right, so this is one other thing. So we'll find less literature talking about the safety and well-being of the researchers themselves when we work in this area. So let's say, we can have people, subjects who are participants in the study. They may come across differently on that day, could be bring some negative experience, even aggressive. May look aggressive, but we don't take things personally, because the adverse experience they have been through their life, when approaching seeking healthcare, has been really probably shows in that kind of perception that they have been kind of communicating. We have lone working policy, which means we don't go alone. We have 2 people at least who go out to recruit and collect data from these participants. And also dynamic risk assessment. So let's say I'm talking to someone in the street, doing some data collection. I do risk assessment. Who else is there? How do I maintain my safe space? So dynamic risk assessment. It may be safe to start with, but it may not be safe, for all the time that you're there. And even going into patients' houses, temporary accommodation. So we have pharmacists going out. We've now got that report. Maintain. Do your risk assessment. Do you think it's a safe space to go? Are you comfortable? And that's where the questions come. Right. So that's all I had to share in regards to my own experience working with the most destitute in the society, and I would like to acknowledge all the funders, the support of which has been really phenomenal. And this Phoenix trial is funded by NIHR, and anything I've said is not NIHR's view. It's my own personal research journey through the trial and the previous studies. Thank you.
Thank you, Professor Bivu Paudyal. So you have talked about the vulnerability and the research among those who are vulnerable. As we all know, vulnerability, it can be social, it can be cognitive, it can be environmental, similarly it can be emotional also. So when you are working with homelessness, which is the best way to take the informed consent, how to enroll the patients, and how we can use the family members in cases of the participants who are intellectually challenged. You have nicely described that. Thank you.
Thank
for a
you.
nice presentation. We'll take up the question and answers all together at the end of the session. Now I would like to call our next presenter, Mr. Jabindra Bhandari, PhD in Global Health and Health Systems. He has more than 2 decades of professional experience in health sector, health systems governance, social and anthropological research in health system. He has worked in UN systems, INGOs, bilateral organizations, NGOs in Nepal. And presently he is the consultant for WHO and also affiliated with Central Department of Anthropology, TU, Kirtipur. Please, sir. And he'll be talking about the anthropological approaches to health system research, a scoping review.
Good afternoon, everybody. Respected chair and co-chair, and all the respected representatives, the audience. First of all, I would like to thank Nepal Health Research Council for this opportunity to share some of my the insights on the topic at the anthropological approaches to the health system research. And I think this is a very I'm truly honored to be here and to present on this. So, considering the time frame, so I would like to be a little bit brief on that, and then I would like to present some of the perspectives and insights on how anthropology and the research methods in anthropology can contribute in health system research. We have been doing that, there are so many research approaches, social, ecological, more scientific or other, there is growing dominance of health research here. But I think it is one of the ways to look at how anthropology can contribute, particularly the medical anthropology can contribute to health system research. So I will try to present some of my perspectives based on this scoping review. Basically, as we know that the anthropological approaches, for example, the ethnography and other methods, anthropological research methods, these have been quite insightful, these have been quite enriching to address so many issues around health systems, which are probably cannot be captured from other research methods also. And so, as we have been hearing throughout this 3-day summit, we are thinking the globalization, these health inequities, and so many other contextual factors which are beyond health sector specific, for example, social, economic, political, psychological. There are so many other contextual factors that also contribute to the health outcomes. That's why, this anthropological approach is gaining some sort of recognition in the low and middle income countries in particular. One of the points I would like to reflect is that we have been talking about the social determinants of health, but perhaps it has to go beyond social determinants. So we have been talking about the wider determinants of health now, and our Nepal Health Sector Strategic Plan for the first time has clearly articulated about the wider determinants of health. So it has to be beyond social. That includes definitely social, and then cultural, economic, psychological, and political context. That aims to, or that tends to shape the health outcomes, and we need to really address those factors or those determinants also. And one of the understanding that we can draw from it is that health systems are, the larger social systems. It is not specific in the hospital or health facility or health units. It is governed by the health systems. So it is much broader arena there. So this scoping review in specific tries to attempt that, how ethnography of health system is theoretically informed and can provide deeper insights on power structures, relationships, and inclusive governance. If we look at the health system, whether at the federal level or whether at the province level or at the local level, if we imagine or if we visualize those health systems at 3 levels, we can see different institutions are there, people are there, communities are there, health providers, politicians, a range of actors and other institutions are there. And their role has been crucial. They are playing some direct and some indirect role in terms of what we are calling about access to healthcare or the enabling environment or, hindering environment. So all these social context is also governed by all these factors and the power structures and the relationship and the governance. And if we can see, for example, the interface between, for example, the local governments, if we can take an example, and then the health facilities and the health service providers, and the communities are people who need health services. So it's a kind of triangular, structures, and in between, there is power relationships, there is communication relationships, and there are so many interconnectedness in between them, and that has to be also, assessed or to be considered. So, this is particularly the scoping review of some of the published and the grey literatures around health system research in the anthropological scholarship. So it aims to explore the scope and relevance in terms of significant contribution of ethnography, which is the research methods in anthropology, in health system research. I would like to summarize, based on my scoping review, some of the insights that we can draw and some of the findings. So ethnographic of health system largely help explore and gain deeper insights on how people, it is largely the people's perspectives. Our health system also recognizes the value of people's ideas, people's perceptions, people's knowledge, people's choices also. So how people produce, how people engage, and how people use local policies, services, programs, whatever system there. And that context, how that shape and enact or, resist the health agenda. What are their priorities? How, what is health for people? So we need to also a little bit explore, not just for healthcare giving or health receiving perspective, but how that phenomena, how that process is governed by all these factors. So this is another way, another perspective of looking at healthcare or health systems. Again, this provides important insights on the culture, economies, politics, and governance of health systems. I think in today, or yesterday's presentation also, how politics supports, political engagement or how political science is also useful in defining and redefining health systems. Again, the culture thing and the economy. And our respected honorable member in the inauguration time, he also highlighted how health economics also facilitates or contributes to health system strengthening kind of things. So, so anthropology is more interdisciplinary scholarship that also includes economics, political science, psychology, sociology, and others. Another interesting part is that we need to mobilize the power of ideas, the people's ideas, in order to influence the ideas of power. That is to say, those with power to make decisions. So when people have power to express their choices, to express their concerns, to express their, what they want. It's a part of the transparency and visibility also. So how power of ideas influence the ideas of power? It's a kind of two-way relationships. It is a bit repetitive, but it also provides, again, the economies, politics, and governance. As I mentioned earlier, that health systems are more social system. It has to be beyond health sector also. And now, the popular strategy or principle is health in all policies. So health is related to agriculture, water supply and sanitation, food, environment, and so many sectors to be included. And it is more emphasis is on more the social protection, because there is the vulnerability, there are, the marginality, and then there is a limited access to the people, the unreached people also. In that context, the social systems also need to be assessed. And these social systems are locally situated and shaped by local ecological, political, economic, and social determinants. And again, the power of politics and the history also. I think we need to also look at how the disease and how the health and risks and all these are, perceived by different people across different times, across histories. So it has to be also to be addressed, and the the ethnography can help to track those understandings also. So I'm trying to be concluding, sorry for that, only 1 or 2 minutes. The conclusion is that anthropological approaches offer more deeper insights on people-centered views of health systems, its actors, and the complexities that we are talking about in the global health or even health systems at all levels. And all these health systems are grounded with power and politics, as we know, and these are shaped by history. And there is a clear need to raise anthropological voice in health system research, because it recognizes and it values people's perspective, people's choices, people's understanding, and all the inequalities that we are talking about. So it has to be also acknowledged in policy, in programs, and health system research. With this, I conclude my presentations, and thank you very much for your time and attention. Thank you very much.
Thank you, Mr. Jhabendra Bhandari, for a very interesting presentation. We, being the health professional, we look at one problem from our perspective, technically only. But when the anthropologists look at the same thing, they make the observations and they pursue the perspectives from diverse angles and different ways, which we normally, health professionals, do not think. And suppose if we give the example, like regarding the food, if the doctor thinks like this food is nutritious because of these values, but when an anthropologist thinks about it, like about the food, who is preparing the food, how the food is coming, and different group of people, how they acquire their food and how they share it. So this is a very interesting topic you presented, how health system incorporates culture, politics, governance, and all those. Thank you, sir, for the nice presentation.
Now we continue to have a talk on different interesting topics. Now it's my pleasure to invite Professor Julie Balin for her talk. The talk would be Federalism and the Health System in Nepal, Identifying 5 Key Priority areas for Action. And Professor Julie Balin is a Professor of Health Systems and Global Change at Canterbury Christ Church University, UK. She is a research leader with more than 20 years experience in global public health, health policy, health system research. Julie has worked in Nepal for over a decade. Since 2020, she has been co-leading with Professor Shimon Roston, a research group on federalism and the health system in Nepal. Throughout her career, Julie has produced over 60 peer-reviewed publications, has engaged extensively with policy and media, and has taught and supervised thousands of students, all of which she is extremely passionate about. Julie, it's your floor now, and we would like to listen what is on. Thank you.
Thank you very much. Namaskar. Thank you. Namaste, everybody. मेरो नाम जुली बालन हो म Canterbury Christchurch University को Health Systems and Global Change को Professor हो म मेरो साथी Professor Simon Rushton मिलेर Nepal Federal Health Systems Project Joint Lead गर्दैछौँ मेरो प्रस्तुति को विषय federalization in the health system in Nepal. Great opportunities, new challenges, and persistent old habits. मेरो म मेरो टिम को प्रतिनिधित्व गर्दैछु अब म प्रस्तुति इंग्लिश मा गर्दैछु. Okay. Okay, so the rest in English, thank you. Okay, so I'm going to talk about the federal system and its impact on the health system in Nepal. And we have these two different systems of governance. We've just heard from our previous speaker about the importance of political determinants of health. And so this is really about governance and politics of health. We have the unitary system in which the power is contained in the unitary level and then shifted down to local levels, or the federalist system such as we have now in Nepal, in which the constitution gives the powers to the federal but also to constituent governments, so in other words, provinces or states or cantons. So what is federalism? Well, it's a mode of government that combines this general government, the federal one, with regional governments in a single political system, and it divides the powers between the two. So you can see here there's powers of the federal government, powers of the regional government, and the shared powers. And why might countries choose to federalize? Well, there's several different reasons that countries might choose to federalize, all of which are listed here. And in the world, we have already 25 federal countries that represent over 40% of the world's population. This includes some of the world's largest and most complex democracies, such as Brazil, Germany, India, Mexico, and the USA. So in Nepal, we've had federalism, which has essentially meant the creation of these 7 new provinces and 753 local governments. And this is the background or the context for our project. And this is just another way of showing the 3 tiers of government in a federal Nepal that you'll all be very familiar with, so I don't need to go into more detail. So in our research, we started to ask the question, how is federalism impacting on the health system in Nepal? And when we talk about the health system, we're using the 6 building blocks, WHO building blocks of the health system, which is shown in the top right corner. And our research, essentially we started off by reviewing and synthesizing evidence, and then doing some data collection at micro, at meso, and at macro level, with the idea that that will all be fed into the policy process and support health system change over time. Hamro anushandan kun tauma boyota. Okay, so our study was in 3 provinces, as well as in Kathmandu. And this represents the rural and remote area, and the hilly and the terai, as well as the urban areas. And within the provinces, we then further selected districts, and within that, municipalities and rural municipalities. So like I already said, we did a mixed methods that included key informant interviews and participatory policy analysis workshops, as well as some quantitative data analysis. Just want to highlight here that we have conducted over 240 interviews and over 30 participatory workshops, and these are some of the participants who were part of the interviews and the workshops. And in the analysis that I'm going to be drawing on today, I've used principles of systems thinking. Sorry, this is not quite as clear on the screen as on the laptop, but here are some photos you can see from some of our workshops and some of the outputs from the workshops. Okay, and this was our most recent multi-level workshop that we held here in Kathmandu in January 2024, where we brought all the three levels, local, provincial, and federal, together into one room. And you can see this session, which was hosted by the chair of our advisory board committee. So, Adzamo muketin notizaharu prostit gordechu. Sorry, excuse my Nepali, but essentially we had so many results. But today I just want to present three because I only have limited time. So the first is that federalization is a complex transformation of an already complex health system. So we can think of it as a very simple, okay, we had a unitary system. If you look inside the box, that's A. It becomes B, a federal system. But we know the reality is not like that. The reality is more like outside of this box, where it's very, very complex and not linear and not easy to do. So if federalism had been easy, we would have already done it perfectly, right? But it's very, very difficult. And our informants described federalism as both an opportunity and a challenge. So that suggests that how it's implemented is actually more important than what the intended design of the federal system is. So we have to remember this complexity. The second the second result I want to bring to you is that federalism is an ongoing, dynamic, and incomplete process. So we are simultaneously phasing out the unitary system, so if you look here at the orange line, as well as at the same time institutionalizing the federal system, so that would be the blue line. And of course, in the context, in the middle of all of that, there will be some conflict, there will be some challenges. And what we have to remember is that federalism is a process, and so the people and the social process of federalism is important, not only the structure. So it is a structure, but it's also a process, and sometimes we can forget about the process. And it's unfinished, so there's unfinished business. We still have lots of new legislation, new regulations, and new policies that are still needed. They haven't been created. So we're operating in this kind of very complex system, but it's still unfinished. And also there's uneven progress. So we found uneven progress in our different provinces, as well as different building blocks of the health system, and also different governance levels. So mid-course corrections might be needed. And the third finding is, excuse me, the third finding is that, yes, federalism has brought some improvements, but it's also brought emerging challenges. And at the same time, we still have persistent old habits. So while some of the structural aspects have improved, like I said, new challenges have emerged. And some examples of this are that decision-making autonomy at local level has improved, but then its spending capacity hasn't quite improved yet. Also, we found improvements in access to health services, but not necessarily in their quality. So these are just some of the findings. And what we heard a lot, or what we heard about, is that actually some people, particularly at federal level, there's a lot of holding on to the old ways and the old systems. So we cannot have a new system until we let go of the old system. And this is obviously a cartoon, but hopefully it explains what I'm trying to say, where we have one person who's saying, okay, I've installed the new system, I've installed your federal system, but unfortunately it won't work until you uninstall the old system. So we need to also uninstall the old old mindset, the unitary mindset. And that's not easy to do. That requires unlearning old habits that are ingrained. Other new challenges that arose are the unclear power and authority of provinces. So we still need to work out a lot of exactly what the role of the provinces is, as well as a lack of coordination mechanisms between the different levels and between the health system and the outside of the health system. And so those are some of the existing challenges. We have lots of other findings, so please, if any of this is of interest to you, I would encourage you to look at all of our publications, which you can find here. And in fact, we just had one additional publication accepted about 10 minutes ago, so there'll be one more to add to the list here. So please do look at all of our findings. And so I just want to mention one caveat or limitation, which is that it has been very difficult to tease out the impacts of federalism from the other ongoing positive trajectory that Nepal health system has been experiencing for many years, as well as the everyday challenges that are faced by a health system with resource limited, in a resource limited setting, as well as, of course, COVID. The last couple of years, while we've been doing this study, there was, of course, COVID. So it's been very tricky to understand what is the impact of federalism, what is the impact of other shocks to the health system. And each of these issues or shocks interconnect in different ways, adding layers of complexity and new forms of resilience as they impact on people's lives. So I note that my time is up. I just have a conclusion that I'd like to just briefly say that federalization remains in a transition phase. And our results have helped to conceptualize this transition through a systems thinking lens, as well as identifying important entry points for health system strengthening efforts in a federal Nepal. And these can be found in our policy recommendations, as well as the other publications I've mentioned. All I would like to say is thank you, Dhanyabad, and Ro Naya Borsa 2081. Ko Subhakamana. Thank you very much.
Thank you, Professor Balan. Actually, it's a very complex process. You highlighted it in briefly. 10 minutes is not sufficient to talk about federalism and impacting health system. Both are complex, and our constitution ensures that there are 3 tiers of powers in our country, and every power has level has the impact on the health system also. So who wants what? That's the important thing. And so this is a transition, no doubt. Thank you very much. And anybody who is interested, and the question answer will be at the end of the session, presentation. Thank you very much.
Now I would like to call Abriti Arjel, Ms. Abriti Arjel, to present on the topic Participatory Action Research to Address Gender Norms and Power Dynamics of Female Community Health Volunteers in Nepal. Ms. Abriti Arjel has more than a decade of experience in health system and social research, with specific expertise in implementation science and applied research. She brings rich experience in an application of qualitative tools and techniques, participatory action research, health policy and system research, and community engagement, considering the aspects of gender and intersectionality. The floor is yours.
Thank you, chairs. Respected chairs and all fellow members, today I'll be talking on behalf of the team. I'll be talking our experiences of applying participatory action research, particularly to address the gender norms and power dynamics of female community health volunteers in Nepal. So as we all know, we have around more than 52,000 local women who work as female community health volunteers, as a close to community providers, and are regularly engaged in community-based preventive and promotive activities. During this process, they do face a number of challenges, and the effect of gender norms is one of them, which is further triggered by the dual responsibility, that is their household, the responsibility they perform at the household level, and their professional responsibility that creates a challenge to perform their to work. So it is very important that these norms are taken into consideration and these norms are addressed for them to work effectively and efficiently. So in this process, to address the gender norms and power dynamics, we applied participatory action research, where we engaged with 12 female community health volunteers of Chandragiri municipality, and also were engaged with different stakeholders, which included municipality officials and also health facility and ward representatives. So in the process, we started the process with the sharing of the findings from our phase 1 study that included the formative phase, where we tried to identify various factors or gender norms related to gender norms and social factors that actually influenced or affected the working ability of female community health volunteers. So presenting and sharing that experiences and the findings, we conducted problem tree analysis with female community health volunteers and stakeholders, where we tried to identify the root cause of that was leading to the problem leading to the challenges that they are facing. So in that regard, they themselves were engaged in identification of the solution. So they came up with an idea to develop a film, that is a participatory video making, to address the gender and social norm that they were facing while doing their work. So in the process of intervention development, they were engaged in series of workshops where they participated and where they were engaged in writing the script for the story, getting engaged in, they were equipped with the capacity to use GoPros, sound recording system, community filming, and several other aspects. So with this process, they were able to develop a film with the technical support from the research team, and then which were showcased at the community level and also now available in different social media platforms. So all these processes were further evaluated using observations, reflective workshops, interviews, and discussions. Just to touch more on the identification of the root cause. So they identified the two problems using the problem tree analysis, that was lack of recognition and unanticipated mobilization of FCASBs. And then with the scoring, they decided to focus more on the lack of recognition, from where the root causes for what was the root cause of lack of recognition was further identified, which included low respect, lack of awareness among the community people, and lack of attention from the higher authorities. So in order to address those root causes, they came up with an idea to co-create a short video which reflected their lived experiences, engagement, and challenges, which was further influenced by the gender norms and values for increased family and community support. So after, as I mentioned earlier, that the films or the participatory video were showcased. So when we talk about the reach and talk about the feasibility of this approach, the co-created video were showcased to almost around 353 people at the community level at 6 different wards, and the participants included different levels. For instance, ward representatives, school principals, health workers, female community health volunteers, family members, members of other different local organizations. In addition, it was also showcased on Female Community Health Volunteers Day, and now it is also available in social media, which has more than 1,000 views all over, and which is increasing every day. So we are very happy to say that. And if you all are really interested to watch the film, you can go to the YouTube and search a story of female community health volunteers, where you can find this participatory video. So while engaged in this process, and when we tried to assess, like, okay, so what was the impact of this? As female community health volunteers mentioned that This enhanced the recognition of female community health volunteers' work. So this created better understanding of the work by the community people, the family members, and also the stakeholders, particularly the dual responsibility which they have been performing and which was not recognized or sensitized previously. So it also increased appreciation, realizing how FCSBs are working hard and how they are devoted for the good health of the community. So if you look at the quotes there, which says, after watching the video, I realized despite working day and night without complaining, FCSVs face many hardships and challenges, and they are less respected and appreciated for their hard work. So today, I would like to thank them from the core of my heart. So this was something said by a community participant during the showcasing event. However, FCSVs also realized that additional initiatives are needed to further enhance the community understanding in terms of the roles and responsibilities they are performing, and also how hard they are working to get things done. Further, this also has increased showcasing the video where they have illustrated the gender norms and the dual responsibilities they are performing. It has also increased support from the family members to do their work. So if you look at the quote, which is very interesting, that says, one of my fellow FCSB friend who is retiring soon said that she showed the video to her husband, who usually didn't help her with the household chores. After watching the video, her husband started to help her, and she felt that if she could have shown the video earlier, her husband would have understood sooner. So this shows like, okay, so how the impact has been made at the community level to change the behavior and to change the perspective of the community and the household members towards them, and how the support can be enhanced for them to work. So also the current FCSVs mentioned that female family members, it has become easier for them to go to work as family members have now started to understand them more better than previously. So in addition to those impact and behavior changes, also at the personal level, female community health volunteers have noted enhancement in the self-confidence, use of technical advancements, and then also in the communication skills, where they themselves kind of facilitate the entire showcasing event. They hosted it, they anchored it, they invited the participants, and then like they were kind of giving the remarks and everything. So everything was co-created and then was led by female community health volunteers, which also helped in the capacity development. And in addition, the video making process or the video is considered as one of the effective tool and innovative approach to communicate the information, where one of the watchers also mentioned, as people forget things, they listen, but when they watch, they never forget. So it is a good way to make people understand things and convey messages. I think the video has depicted the truth. So coming to my last slide on the key learnings. So participatory video making or participatory action research is a collaborative and inclusive process where we try to engage different stakeholders and identify local issues with the local solutions. But then like there is less clarity at the very beginning when you start the process in terms of what action plan is going to be. But then this process is also adaptive and flexible. Therefore, you have the opportunity to make joint plan with the participants, in our case with the FCSVs, as per their feasibility and availability. However, the adaptability and the flexibility sometimes can be time-consuming and challenging in terms of timely engaging and getting the output. But then storytelling was used and can be used as a great and a powerful advocacy tool to raise awareness, as which has been also seen in our case. And but in this scenario, the trying to explore and understand the gender norms and aspects of equity and bringing this into discussion was very challenging. It was not a one-go process where we just went and asked like, okay, so what are the gender-related issues that you are facing, and then they directly could answer it. No, we had to try a lot and give several examples to make FCSVs themselves understand, so what exactly is gender norms, or what exactly is social inequity, and then like what could have kind of impacted them. So overall, it has been an empowering and capacity development process and approach, not only in terms of enhancing the capacity of the female community health volunteers, but also in terms of sensitizing the community and also the stakeholders to understand the gender dynamics and the gender norms shaping the experiences of female community health volunteers, who are a very important cadre in our health system and act as a frontline health workers. So thank you, everyone.
Thank you, Ms. Abriti, for the nice presentation on participatory action research to address the gender norms and power dynamics of FCHW. We all know that FCHV, they are always overburdened. When a government brings any new programs, we look for the FCHVs because they have the access to each and every household of the villages, of the town. So, for the success of any government programs, any programs of the NGOs and INGOs, they are supporting us so much that they are actual heroes of our community. So let us all give a big round of applause to the FCHVs of our country.
Now, to continue talk, I would like to invite Mr. Achyut Bikram Thapa. He is talking on medicines, registration and marketing authorization in Nepal, comparative study for benchmarking best practices. And Mr. Thapa is a pharmacist by profession. He has done masters in pharmacy and he is a PhD scholar at Kathmandu University. He has more than 17 years of experience in pharmaceutical manufacturing and quality assurance system in Nepal. He has currently working as senior technical advisor for USAID funded promoting the quality of medicines plus implemented by United States Pharmacopoeia in Nepal. Mr. Thapa, floor is yours.
Thank you. Dear Chair and Co-Chair of the session and all invited distinguished guests, it's my honor to be here addressing on some of the permanent issues related to medicines. Previously, we talked about 6 building blocks that were more related to workforce, and from our perspective, this medicine aspect is a bit shadowed area, so we need to talk about the quality of medicines, what's the quality and what is the main indicator or what is the main promoter for that one, what is the role of our national regulatory authority in Nepal. So this is one of the comparative study with respect to Nepal's National Medicine Regulatory Authority, Department of Drug Administration, with international best organizations, what we call as key regulators. And this is aligned with the efficient and responsive health system, quality and equitable health services. Okay. So this is an study conducted by 3 of us, and I will be representing all our team, and it's a part of Kathmandu University School of Pharmacy as well as United States Pharmacopoeial Convention Nepal, promoting the Quality of Medicines Plus program. So talking about our National Medicine Regulatory Authority, Department of Drug Administration, established in 2035, established in 2036, Bikram Sambat after the Drug Act 2035, and this is the authority for that ensures the availability of quality, safe and effective medicines at affordable cost throughout the nation. And it is for the control of import, manufacturing, storage, distribution and consumption of medicines in the Nepal. And recently, previously it was more directed towards the medicines. Now with the amendment and with the directives, now it is covering also the medical products and health technology products as well. So now global benchmarking tool is another part of WHO and that has been initiated by WHO from early 1997, and recently in 2013, the 6th version of global benchmarking tool has been initiated, and that checks all the regulatory functions under different 9 areas, 9 categories, and this is an indicator-based system. And in this system, the global benchmarking tool, the regulatory function overall is addressed and overall regulatory function is checked. And under this, we have 56 indicators, and we have 56 indicators for all 9 functions along with 268 sub-indicators. So today I will be discussing on only one function, that is registration and marketing authorization system, and it has 6 indicators with 35 sub-indicators. And based on this global benchmarking tool, the regulatory authority is classified as maturity level 1, 2, 3 and 4, 4 being the highest one. So it is related with the WHO resolution 67.20 in 2014, so that every regulatory authority in the world that should be in maturity level 3 by 2030. So to align with this, DDA was self-benchmarked on the year March 2021, and based on that one, DDA now stands at maturity level 1, that means the basic one. And to align with the World Health Association resolution, Nepal Health Strategy has also envisioned that by the year 2030, Nepal will be in maturity level 3. So as a part of our activity, PKM Plus program is supporting Nepal National Regulatory Authority to move ahead with the maturity level, increasement of maturity level. So another aspect is WHO listed authority, WLA. WLA is a new concept that emerged from March 2022. The authority with highest level, they are now termed as WLA, and currently we have only 3 countries regulatory authority in the world as WLA. That includes MFDS Korea, Swissmedic Switzerland, and Health and Health Science Authority Singapore. So another aspect is the SRA. SRA is a rather old concept institutionalized by International Council on Harmonization for medical products for human use, and that consists of 3 major parties: the European Union, most of the countries of the European Union, Japan and the United States, and currently this SRA has 36 countries. Out of 36, 31 entirely from the European Union and communities, and 3 as observers, Japan and United States included. So as a methodology, we have conducted semi-quantitative questionnaires formulated based on the global benchmarking tool, and all the indicators and sub-indicators under marketing authorization function were assessed, and the data from the DDA were all assessed regarding these questionnaires that matches with the indicators and sub-indicators under the maturity level 1, maturity level of marketing authorization function. So for comparative study, we have selected one ML3 country, that is South Africa, because PKM Plus program is also running in South Africa, and another one was Saudi Arabia, which was recently graduated as marketing as ML4 authority, and WLA, 3 WLA. Out of 3 WLA, we have compared this study with HSA Singapore and Swissmedic Switzerland, and out of SRAs, out of many SRAs, we selected SRA, Swissmedic as common, WLA as well as SRA country, and Switzerland, TGA Australia, and Health Canada. So now talking about the results part, that is more focused on the legal provisions. DDA is working as a drug evaluation and from the drug evaluation and registration division. That is one of the 3 divisions in DDA, and that is the core division responsible for marketing authorization function that issues marketing authorization for both domestic as well as imported products. And that is being that performs its actions based on the mandate as provisioned by Drug Act 2035, Drug Registration Regulation 2038, Medicine Registration Guidance 2073, and Codes of Use of Medicines and Vaccines 2077, the latest one being added during the time of COVID. So there is a three-tier dossier review submission and review system, the officer being the first level of reviewer, that is followed by the head of division. So he or she will review the second layer, and Director General, the head of regulatory authority, is the final signatory authority. And DDA follows a hybrid system that has some paper-based system as well as some software-based system for the review of the documents submitted by the manufacturers or the importers. So we have 6 officials as first line reviewers, 3 of them assigned for import section and 3 for the domestic sections. So average registration turnaround time is 49 days. That ranges from 7 days, that is being the shortest time, and the longest time being 99 days. And this is one of the shortest time required for the granting of marketing authorization within all the other comparator countries that we have studied. So I will be talking about more on 5 different areas that we have studied for as a comparative study. First one being the type of assessment model, and currently DDA doesn't have the common technical document, that is the basic requirement as mandated by International Conference on Harmonization ICS guideline. So DDA has not approved the method of ICS approval, and so the second and third section, non-clinical review and clinical review, is now not considered by DDA. And again, for the first type 1, that is called as verification review. That means if the product is being already approved by 2 or more of the stringent regulatory authorities, then the product will be automatically registered in the DDA. So that is one of the factors behind the quick registration time in the DDA. And the average registration means that if the product is being registered to any one of the SRA or stringent regulatory countries, the product will be registered automatically. And the full review type, that means there will be a review of chemistry and manufacturing control CMC part, there will be review of non-clinical part, and there will be review of clinical portion. So this detailed review is not being considered by the regulatory authority of Nepal. And another part, quality measures implemented, that tells more on QMS system implemented by the regulatory authority of Nepal. We have one quality policy and quality manual. Based on that quality manual, the regulatory quality QMS system is guided. However, there are lack of standard operating procedures that guide the first reviewer, second reviewer, and final approver for the licensing of marketing authorization. And there is no quality department that is dedicated for marketing authorization approval. And there are some shared responsibilities that has been defined in the laws and bylaws, including the guidelines. So all other countries, higher authorities, maturity level 3, 4, and SRA and WLA countries, they have all these functions. More or less, they have all the functions. Like internal quality policy in case of Singapore is not applicable because they do not want to go with the internal policy review. And third result is on transparency and communication parameters. This is one of the lacking area where we are facing deficit with respect to advice to the industries. We don't have much more results related to transparency and communication. And approval time, although it is published, it takes a lot of time for that one. And advisory committee meeting is not finalized. The fourth one is continuous improvement initiative that includes human resource development part. And there is no mechanism of internal audit, although other parts they are formalized.
I think you can discuss in
the last one, sir. So this is the last one, and regulatory workforce improvement, and we have on-the-job training and induction training for the part for our assessors, where other parts they are lagging. And conclusion, as a conclusion, we are working as a limited human resource part, and the work is condemnable. Thank you.
Thank you, Mr. Thapa. It is interesting, DDA's responsibility, registration and comparison, how we market the medicines, drugs in Nepal. And still we are maturing level 1 and targeting to 2030 to be mature level 3. So a lot of things, a lot of things are not seen. Maybe there is no trial, that's why we are not assessing so much. But all the molecules in Nepal that is used in human health should go through the DDA, I think. That's why it's very important to have maturity level 3. I think at least 3, not even if not 4. So you have highlighted where we lack the things, and also I think policy maker and also DDA should work on it. They always complain of lack of manpower anyway. That's something we have. So with this,
I would like to call Anjali Joshi to present public health competencies in Nepal, current status and way forward. Anjali Joshi is a public health graduate with specialization in global health from Kathmandu University School of Medical Sciences. She has been working as a project coordinator at Dhakal Hospital, Kathmandu University Hospital since 2022. She possesses a handful experience of research on the area of migrant health, child health, climate change, and public health education. Anjali Joshi, please present.
Thank you, ma'am. Good afternoon, everyone. I'm Anjali Joshi, and I am from Dhakal Hospital. And today I'll be presenting regarding the findings from our study, that is public health competencies in Nepal, current status and way forward. So this study was conducted on behalf of Consortium of Academic Institutions for Public Health in Nepal, which works collaboratively to advance public health education and training in Nepal. And this consortium consists of 9 different universities and institutions that are currently running public health programs in the country. So the public health education has evolved since 3 decades in the country, and by each year we have a number of graduates are increasing, and we have our regulatory bodies as Nepal Public Health Professional Council and Medical Educational Council to regulate the standards and quality of public health education in Nepal. Looking on to the current scenario of Nepal, there are limited job opportunities for the public health graduates, with the poor job satisfaction among them, and lacking job-specific public health competencies in the graduates. In order to seeing this scenario and considering this scenario, we tried to conduct a study to assess the public health competency in Nepal, and which aimed to assess the public health competency in Nepal through curriculum review of academic institution and measure perceived public health competencies being acquired and utilized by the public health graduates. We conducted a mixed method, sequential mixed method study involving 3 phases. The first one was curriculum review of the 9 public health institute of the country, and 48 qualitative interviews with the public health professionals that were engaged in government, non-government, and academia sector. And we also conducted quantitative survey among the recent graduates. And this study was conducted in all the 7 provinces of Nepal, including 9 public health institutes and universities. And the qualitative findings were analyzed through thematic analysis, and the quantitative findings were analyzed through descriptive analysis. Based on our curriculum review, the course content varied significantly among the public health institutes, and they usually used examination method, practicums and fieldworks for their assessment method, and they used percentage and letter grade system for evaluation. And the program structure was in 2 modalities, that is semester and yearly system. And there was a compulsory individual thesis requirement for the students in both, either in undergraduate and postgraduate program. So we observed some of the areas of improvement in the current curriculum of the public health education. The first one is curriculum harmonization. In order to set a set of standards among the graduates in the country, and our curriculum requires timely revision and including emerging and relevant public health issues, and the current curriculum should align with the international standard and competencies, and there is a much need for inter-organizational collaboration in the country. So, sorry for this messy slides. Our qualitative findings were analyzed in 5 major themes. The participants in our study suggested some of the major roles of the public health professionals as program management in terms of overall planning, coordination, evaluation of the public health programs in the country, coordination and collaboration with several sectors, and research and evaluation. The existing competencies among the graduates were theoretical knowledge of the public health subjects, leadership, coordination, collaboration and communication, decision-making skills, and the required competencies suggested by the interviewee were coordination, collaboration and communication, data management skills, leadership and management skills. We identified core competencies gap among the public health professionals as limited proficiency in utilizing advanced technologies, underutilization of research knowledge and skills, gap in education and training, and poor utilization of the knowledge, utilization of the training in terms of knowledge and skills. And the major opportunities in the field of public health is the growing awareness on preventive and promotive care, digitalization of health, and federalization. And the current challenges in terms of public health sector is limited job opportunities, retention of the competent public health professionals in the country. And our participants suggested some of the recommendations for the education institution as to emphasize on practical experiences and foster collaboration among the academia, government and non-government sector. So for the quantitative survey, we estimated a sample size of 409, but we could only gather 91 survey from till date, and the existing status of public health graduate in Nepal. The mean age of the participants were 24.4 years, and majority of them were males, and their highest level of education was Bachelor in Public Health, and majority of our participants were from Purvanchal University. So the current occupational status of public health graduates, like 45% of our participants were engaged in private job, 5% were engaged in other sector, 11% in government job, and 18% were pursuing their higher education, and 20% of the participants were unemployed, and only 1% were engaged in the academia sector. We also analyzed the perceived public health competencies of recent graduates. The tools was adopted from the Public Health Foundation, and it consisted of 8 major domains, and the results were, or the responses were measured in terms of Likert scale, 5-point Likert scale. And our participant has more competent on the second domain, that is policy development and program planning skills, and were less competent in the seventh domain, that is management and finance skills. We also measure the perceived major responsibilities of the public health professionals. So our majority of our participants responded as communication, networking, and advocacy as the major responsibility of a public health professional, followed by data collection and analysis, program implementation, research preparation, and program planning. So we also asked to the employed public health graduates whether they were satisfied with their current job, and among the employed participants, 53% were satisfied with the current job and 47% were unsatisfied with their current job. And the aspects of job satisfaction were career growth, benefit and salary, positive work environment, and the reason for job dissatisfaction were low salary and job insecurity. So based on our study, and our study suggested as the need and importance of networking among the public health institutions and other government and non-government sectors, capacity building among the students and faculties, cross-learning opportunity among the institutions, and overall enhancing the public health education and practice in Nepal. And the consortium has initiated or started a kind of initiation in terms of addressing all these issues. Like we have all started capacity building program for the faculties and students, and we have recently organized public health student conference where the students were able to showcase their findings and work in the conference. And also we have networking with all the public health institutions in the country. So here ends to my presentations. Thank you all.
Thank you, Ms. Anjali Joshi, for a very interesting presentation. Like this public health competency, it is really interesting. And the different domains it encompasses, like the 8 different domains she has discussed, is very important. It's time we also should think about how are our graduates, whether they are satisfied with a job or not, and what is the way forward. She has nicely depicted. Thank you so much. Now, I would like to call our next presenter, Mr. Ghanshyam Gautam. Dr. Ghanshyam Gautam, he is a health economist possessing more than 20 years of experience in health policy and system reform, social protection, evidence-based planning, and capacity development. His key areas of expertise include policy and planning and capacity development, strategic reform, health system strengthening, health financing, universal health coverage, and policy research are also his areas. And he currently holds the position of lead in health economics, systems, and social protection at HERD International. Throughout his career, he has worked with government entities, international organizations, bilateral and multilateral agencies, and national organizations in the areas of health policy, systems reform, and governance. The floor is yours.
Thank you. Respected chairs, scientists, researchers, all the participants joining here and virtually. So on behalf of the team, I would like to present on multi-sectoral coordination for health from the perspective of 3 provinces in Nepal in the current federalized context. So just to start with the context, health is a multidimensional issue. So we have been hearing this morning that so many different social and economic factors are affecting health. and there are so many social determinants we are talking about in relations to health. And health system functions in a changing political, administrative, and social ecosystem, which again interfaces with multiple other sectors. So there is growing importance of multi-sectoral coordination and collaboration for promoting health, reducing disparities, addressing interconnected health issues that are growing over time, as we see. At the same time, there is opportunity through multi-sectoral coordinations to pool the resources, expertise, knowledge, and tackle complex and interconnected issues across the sectors. Despite this recognition and importance that has been highlighted in the literature, there is gap in the evidence in terms of current practices and coordinations, particularly in our context. So to bridge this gap, we assessed the current landscape, including facilitators, challenges, and opportunities of multi-sectoral coordination at municipal level in the current federalized context of Nepal. So this study was a qualitative exploratory study. The 3 municipalities were focused mainly from Gandaki, Lumbini, and Karnali, and 25 key informant interviews were conducted. Data were transcribed and analyzed thematically. In terms of findings, as we see at the municipal level, there is local health systems where there are political actors led by, for example, mayors and deputy mayors, but besides that, there is a holistic team, municipal council, ward chairs, ward members who basically engage in shaping the policy and planning framework for the sector as well as resource allocation. And there is more managerial actors and sections, departments, structures who interact with these political actors. Health is one of the core within that structure. And health interplays with multiple sectors within that framework, which basically play a role in terms of managing health service delivery and performing the public health functions. These actors interact. There is also health facilities are there in terms of hospitals, basic health service units. There is also HFMC who manage the operation of the health facilities. There is interaction with the community actors. We listened the story of these FCSBs, and there are also mothers groups, so many other community groups. Besides that, there are also federal and provincial actors, so many actors working in the systems for the benefit of the people. In terms of current situation of the multi-sectoral coordination, where we did focus, there were no long-term plan which could potentially bring multiple actors together in terms of shaping the sectors better, working for the people's health. Also, there were few sectoral policies and strategies which, however, we are not really or genuinely informed by the local evidence. They were adopted based on other contexts, other scenarios. So even whatever has been done, that was not really based on the local priorities that was mentioned by the respondents. Similarly, there were a provision of regular meetings and coordination across the multiple actors. However, that was not routinely happening the way it should be happening. As a result of that, multiple actors working within the municipal settings were not really informed about each other. So there was limited scope for them really to coordinate and collaborate across the sectors. Similarly, to a certain extent, it's not like collaboration was not happening at all. Collaboration was happening to a certain extent between the sectors. For example, health and education, health and WAS. For example, school health is one of the excellent examples where health and education are interacting. There are also waterborne diseases where multiple actors are working together. However, besides that, there are also some sections or structures who could potentially, such as planning and finance, like structures within the municipal settings who can bring different actors together. For example, planning sections within the municipal level interacts with all other sectors. Similarly, finance sections is the one which is the center for all others. But that structures had not really been able to effectively coordinate other sectors to really make it happen in terms of collaborative work. Thematic committees usually meet during the planning process, not throughout the implementation phase. That limits the scope of delivering work in a collaborative manner. Despite of these issues and challenges, context, still there is a felt need that focus should be on the collaboration and implementation should be in a collaborative manner. When we go beyond the municipal setting and look with the other actors who interact with the municipalities, there was also no formal structure for sharing and learning with other local governments, for example, provincial actors and other CBOs and local organizations. Within the health sectors, district health offices were playing crucial role in terms of facilitating interaction with them across the municipalities, as well as linking provinces and federal actors with the municipalities. Similarly, there are also other external organizations working within the municipal settings or districts. However, initiations in terms of bringing them together was mainly initiated by external actors rather than within the municipalities, meaning that it was not intentional within the municipal setting, but it was somehow happening. So, in terms of provinces engaging at the municipal level, they were with limited resources to engage with the municipalities, so it created limited opportunity to really facilitate the collaboration across the actors to make the health sector work in collaboration. So barriers for effective multi-sectoral coordinations, there are no routine mechanism, structured mechanisms to have the sectors coming together and work. District level provinces offices realize that local authorities have power and authorities, and they also are with limited capacity, but they hardly seek expertise or technical assistance to make it happen. Also, geographically, sometimes barrier was like offices were isolated. They were sitting in different places. If they were together, that could have provided even informal opportunity to collaborate. There was due to limited structure, guidance, and orientation on multi-sectoral coordination, that was acknowledged as also as the challenge for the multi-sectoral coordination from the health sector perspective. There are multiple actors and limited capacities, which we can see in this slide. When we see the health sector budget, Ministry of Health, for example, at the federal level with multiple actors, holds slightly more than 50% of the budget. Other actors are also there. So within the health sector, there are so many actors we can see which need to coordinate and collaborate with multiple other sectors. But that is not, I mean, for that purpose, we don't really have capacity at the local level. In terms of local self-assessment capacity, the weakest area is collaboration and coordination, where optimal is 100, only around 1/3 capacity is there in the system. This final slide, collaboration for planning and actions occurred only sporadically at the local levels, which was mainly driven by the specific needs or case-by-case basis. Sectoral coordination outside the municipal offices was also functioning mainly from the annual planning process rather than going throughout the implementation phase. Similarly, although stakeholders were found engaged with other sectors, sometimes on a personal basis, sometimes on informal arrangement. There were positively, there were pockets of programmatic collaboration, such as nutrition. However, these were not being tapped or utilized as an opportunity to move ahead with the multi-sectoral collaboration to really minimize the issues of health sector that we have been seeing throughout these 3 days. Thank you so much.
Thank you, Mr. Ghanshyam. You have nicely pointed out the different enablers and the inhibitors for this multi-sectorial coordination. Like when we do any job, when any job needs to be done, understanding the stakeholders' perspective is very important, which is very crucial for the development, for the implementation of any intervention that we do. And this structural approach helps us to work together in very complex challenges and to address the integrated goals like universal health coverage, sustainable development goal. So you have pointed out nicely what are the enablers, what are the lacking points, what is the need for the collaboration. Thank you for the nice presentation. We have completed all the presentations. Now the floor will be open for discussion for 10 minutes. We can take the questions which the presenters can answer within 10 minutes. Any questions for any of the presenters, please? Are we so clear? Okay, one question. Please, can somebody provide the mic? Or you can take this one.
Thank you.
Let's take the first question from back. Please identify yourself and point out to whom the question is directed to.
Sure. I'll use Nepali as a means of communication. मेरो चाहिँ जबिन्द्र सरलाई हो, जबिन्द्र भण्डारी. उहाँले जो एन्थ्रोपोलोजिकल एप्रोच टु हेल्थ सिस्टम रिसर्च स्कोपिङ रिभ्यू भनेर गर्नुभएको छ. भेरी इन्ट्रेस्टिङ. मलाई त एकदम मजा आयो. मतलब उहाँले छोटोमा भन्नुभएको थियो, तैपनि त्यसले धेरै कुराहरू डिपेक्ट गरेको मैले फिल गरेँ. उहाँले अलिकति एन्थ्रोपोलोजिकल एप्रोच भनिरहँदाखेरि अब एथ्नोग्राफीको कुराहरू पनि गर्नुभएको थियो. अलिकति त्यो कुराहरूमा पनि थोरै उहाँले अझ मोर अलिकति थोरै एथ्नोग्राफीमा पनि के गर्नुभएको भन्ने कुरा गरिदिनु भएदेखि अझ यहाँ हुनुभएको अडियन्सहरूलाई पनि बुझ्न इजी हुन्थ्यो होला. म आफै पनि मेडिकल एन्थ्रोपोलोजीको अलिकति जिज्ञासु, अब अलिअलि विद्यार्थी जस्तो पनि भएर एन्थ्रोपोलोजी भने चाहिँ अब मानवशास्त्र हो, तर धेरै जसोले यो चाहिँ जीव विज्ञान हो कि जस्तो पनि सोध्छ. त्यही भएर अलिकति एन्थ्रोपोलोजिकल पर्सपेक्टिभमा एथ्नोग्राफीको रोल मैले हेर्दाखेरि चाहिँ लुकिङ थ्रु अदर सुज भन्ने जस्तो पनि सुनिन्छ जस्तो लाग्छ. अलिकति यो एथ्नोग्राफिक एप्रोचमा हजुरले त्यसको के गर्नुभएको थियो थोरै अझ जान्नु पाएदेखि हामी यो मेडिकल अथवा हेल्थ साइन्सको ब्याकग्राउन्डका साथीहरूलाई चाहिँ अझ आफ्नो रिसर्चमा इन्गेज हुने मौका चाहिँ पाइन्थ्यो. म फुर्बा मोक्तान. थ्याङ्क यू.
Any other questions for the second speaker? I think no. I think he can answer his first question.
Thank you. मलाई धेरै खुसी लाग्यो कि तपाईले क्वेशन सोध्नु भयो अथवा एउटा क्युरियोसिटी काइन्ड अफ इन्क्वायरी ल्याउनु भयो हैन. Because of time constraint, I could not go in details, but I tried to capture how ethnography, which is theoretically informed, and how that can contribute to people's perspective. एउटा लोकल पर्सपेक्टिभमा कसरी हुन्छ भन्ने सन्दर्भमा चाहिँ there are so many areas that ethnography and other qualitative research methodologies can explore. For example, I can take one example from my own experience is that in the local health system, for example, there is, for example, local governments, there are health facilities, service providers, and the people. Basically, this sort of ethnography can help researcher to understand the local context and how, for example, in that case, how social capital is formed, who owns the power, and who owns the knowledge, and what kind of governmentality, like the Michel Foucault says, the knowledge and power kind of relationships. How can the agency is developed? For For example, the poor and marginalized populations, whenever they know the information, when they have knowledge, how can they, enhance their agency, the capacity, or how can they ask for the healthcare services? How can they go to the health facilities and can communicate about what they are feeling about and what is their choice about on the healthcare services? So these are some of the, important areas that anthropology, medical anthropology with ethnography can well, delve into and then try to empower community peoples or even the service providers to interact and to provide these health services also. There are others like the social capitals, capital theory, Pierre Bourdieu's kind of things, So how social capital is formed. For example, in one of the presentation, how female community health volunteers can have knowledge and the capacity, to empower, to facilitate mothers to access health services. So this sort of, agency creation and empowerment, social capital, knowledge and power, and there are different actors in the social system, health systems. So it investigates, it tries to, explore those missed opportunities, I should say, about the power of the communities, how people feel, their beliefs, and the social norms, values, and cultural factors, and the psychological also. So in my experiences, all these factors are somehow missed in our health system. So anthropology, ethnography, through this research methodology can complement whatever research we have done in the past. So it is not only the methodology, but whatever research we have done, all these quantitative, scientific, whatever we call, these are very important, but ethnography or the anthropological approach can better complement, to support those things from people's perspective, from local perspective also. So I think I try to a little bit explain on it. But if you have any further interest, we can also discuss in other times also. But I really thank you and I appreciate your inquiry. Thank you.
Thank you, sir. Any more questions?
मेरो क्वेसन चाहिँ हाम्रो फेडरल सिस्टम बालेन are there any good things after federalization in health systems? If you find the good things, maybe top 3 things, and what could you see the future of federal system in Nepal in perspective of health system?
Thank you. Thanks very much for the question. Yeah, we saw lots of improvements, so there were definitely good things, so I don't want to give the impression that it was only bad things. In fact, we had lots of improvements. Certainly the ability for local levels to make their own decisions, that was definitely seen as an improvement. Also, we did see that there were improvements in the access to services. So there were lots of improvements in bringing services closer to the people, for example. But these weren't, well, and then the top, what would be the third one? I'm just trying to think. Resource allocation, was also...
After federalization. Sorry, I'm complimenting.
Team member.
Yeah, I'm one of the team member. Yeah, so the best results were seen at the local level in terms of more resource allocation, as well as increase in the number of health facilities, like in each ward, and also increase in the agency of people in directly reaching out their elected members and lobbying for themselves, and increase in the access. And whenever there were no access, people were able to go to the ward chairperson and able to tell that we need this and you are not being able to support us. And slightly, but not completely, that is what we are working for, is still the local level is prioritizing other infrastructure development than health. So their capacity building and in understanding the health priority and health system development is beginning to be seen, but not completely. So that is why we need the our work or intervention. Thank you.
Yeah, I think just thank you so much. Just to add, so we do feel there's been improvements, but the mission's not yet accomplished. So there's still some way to go. Yeah. How do we see the future of federalism in health system? Well, that depends on what choices are made today. So, it's difficult for us to answer that question because that depends on the choices that are made both politically. The federalism is a political choice. And so we need to respond also to that choice. And that includes every single person working in the health system responding, as well as the system overall. So it's not easy to answer that question, but I'm an optimist, so I see it optimistically, but it does depend on the choices that we make today that will impact on the future that we have tomorrow. And part of that, I think, like I tried to say, is also letting go and moving forward, because we can't have the new federal health system if we're still holding on to the old system. So I think if we can keep moving ahead, then that should hopefully be positive. Yeah. Thank you. I hope that's answered the question.
Thank you very much. Lucky on the third attempt. So I have a question for Angela from the Dhulikhel Hospital team. It was a nice presentation actually regarding the public health competencies. So I was particularly interested in understanding how did you measure job satisfaction, whether it was just a yes-no question or whether you were using a psychometric scale to measure job satisfaction. And similarly, the other question is regarding the recruitment strategy of your participants, whether it was through online or something like that, especially because, while considering your mean age, it was more skewed towards the younger age, so that might affect the outcome, job satisfaction. So did you try to, understand job satisfaction of public health professionals at different age groups, like young and someone who is on a mid-career and someone is at a very advanced stage or advanced career? That's my question. Thank you.
So thank you for the questions. Our participants were measured recent graduates, either undergraduate or postgraduate, and we administered an online questionnaire to the participants, and they responded accordingly. And regarding the job satisfaction, we we measured the responses based on yes/no questionnaire only. Yeah, I hope I answered your questions.
Thank you. Now I think we have, discussed and presented more than 1.5 hours now. So we must be tired, and this is the last session. We are very happy. We both chairs are very happy that all the presenters presented so much, important topics. That was important. But if you look in the presentation, every presentation was interrelated for me. We presented a piecemeal, like as Professor Balan said, that federal system, lot of levels, but we are looking the different levels in individually. But we have to put together. I think that's how we can have a good health for everybody. So, our first speaker, Dr. Paudel has said that, vulnerable population. So that is related. Anthropologically, also cultural and vulnerability is there. Federal power politics. All these are there. So it's very interrelated. So I think policymaker might coordinate all these piecemeals in one place and make better health for our people. So all the presenters are presented very well, and this is the last session, and all the audience attentively listening and watching the presentation and reading the slides. We are very nice, and I hope you can take something today from this hall, from this last session, to your profession or to your work and utilize it. And tomorrow is our New Year's Day, so I personally and both of us will wish you all the Best and Happy New Year 2081, and New Year, next year maybe we'll meet again here in NHRC Summit.
Thank you, everyone.
Finally, we are at the end of the session, and we have successfully completed the last session on health system and research. So finally, I'd like to thank Dr. Hari Dhakal sir and Professor Dr. Sabina Shrestha ma'am and all the presenters for making the session vibrant. So now at last, I'd like to request everyone to be here for the group photo. All the presenters, please come on the stage.
Which camera to look at?
Yeah, he's doing.